ethics consultant. I represent the Pillar for Ethics at the Center for Medical Humanities and Ethics, and enjoy being involved in conversations about policies and practices at the bedside, wherever I can be useful. I've written about ethics in healthcare. I'm very interested in moral decision making. I've written on secret recordings of doctor-patient conversations. I've written on teaching medical students about interdisciplinary work, and I've written on palliative care and end-of-life decision-making. My interest in ethics really blossomed when I was in graduate school. I do have a PhD in the from the Institute for Medical Humanities, like Dr. Pearson. My focus was on clinical ethics. I'm a phenomenologist. I'm interested in the sources of experience that give rise to knowledge. So that's an approach to epistemology and to moral experience. So my dissertation was on sources of moral authority in doctor-patient relationships. And for me, it all comes down to the organic, real experiences of being wounded and the calling that patients in their wounds give rise to, and the answer that the healer provides in choosing to come to the bedside. So I'm interested in ethical obligations to patients, and I'm finding it really challenging to apply these concepts, not just throughout my career to end-of-life situations, but now to a pandemic circumstance where you have broader issues of rationing and justice and access to healthcare emerge, and in some ways challenge the fundamental nature of the doctor-patient relationship.
Thank you so much, Dr. Morrow. And we've just had some more folks join the meeting. And so I'm just gonna recap a little bit. We've introduced the Center for Medical Humanities and what we do. And there we go. I think everybody should be able to join automatically now. We've introduced the center and what we do. And we have described the hope of our center, and particularly this PanPals effort to preserve and further the moral values that animate our work in medicine through this pandemic and afterwards. So the part of what inspired this meeting today was a recently released paper from the New England Journal of Medicine, where some bioethicists and physicians released proposed guidelines for how physicians might allocate scarce medical resources during the pandemic. So I was going to ask Dr. Morrow to just give us a little bit of an outline of this, and then we will get into some discussion about, number one, does this, in what ways does this paper make sense to us? In what ways does it not make sense? How does it fit with the moral values that we hold dear and that animate our work? What are the sort of, again, fundamental things that we need to hold on to in our practice? I want to make very clear for everyone that we are not, here in San Antonio, we are still very lucky to be in a position where we're not facing scarce medical resources. We still have lots of open beds and open ICU beds. And so we are not in the situation that led these bioethicists to write the paper that they did. We are in the lucky situation of being able to talk about this from a more theoretical position. And also, I want to make it very clear that although both Dr. Morrow and myself work as physicians at university, we don't speak for university, and this is not going to be a how-to about how you should make decisions about your patients when this comes up. This is going to be more of a values-based discussion. Does that seem accurate to you, Dr. Morrow, and is there anything you'd like to add to that?
Yes, that's accurate. I love it. We could be in the eye of the storm right now here in Texas. And frankly, it's always worthwhile to take a deep breath and reflect on your circumstances as they are and as you imagine them to unfold. That's what we're doing. We're taking stock of the situation. We're going to look at some recommendations from experts about how to manage what's coming next. And we'll do so guided by our core ethical principles and sense of commitment to one another. And we can ask open questions, tough questions. It's probably worthwhile right now. You've gestured towards this. I'll make it clear that my opinions on triage and how to handle code status and a pandemic and all that stuff doesn't reflect anybody else than myself. I am fully aware that there are leaders at the health system level, at University Health System, at UT Health San Antonio, and the many health systems in San Antonio and beyond that are working on policies to plan for this crisis and to provide the best level of care to patients at the individual level and to be good stewards for the community. And I don't want to be ahead of their plans. I don't want to try to telegraph or message for them. I'm talking about my own views informed by my own experience and expertise in regards to ethics and clinical decision making. And right now, in a way, we're all on a level playing field. There's so much uncertainty and ambiguity that it really is going to take some collective wisdom to have a sense of what the right next steps are.
Thank you so much. So with that in mind, would you give us a little walkthrough of the New England Journal of Medicine paper that we sent out to our participants today?
Yeah, for sure. So this article is from the New England Journal of Medicine, the Sinai tablets of the medical community. It is a sounding board article called Fair Allocation of Scarce Medical Resources in the Time of COVID-19, authored by Ezekiel Emanuel, among others, most of whom are physicians. This emerges from a New York Times editorial that a few of these authors, including Ezekiel Emanuel, published recently, talking about the same issue, this one with more detail. So the first, I don't know if you can hear TJ defending my home from neighborhood walkers. It's pretty impressive. So the first section of this article talks about the health impacts of moderate to severe pandemics, talking about the demand on our system for healthcare. And there are some projected models comparing influenza versus COVID. If you look at table 1, you can see projections based on moderate to severe pandemic. And for COVID, if there is a moderate spread of the disease with a moderate degree of injury, then it's projected there'll be 16 million ill persons, 1.3 million hospitalized, 960,000 to the ICU, and 80,000 will not survive overall. So the one important number is about 1 million people admitted to the ICU in a moderate COVID pandemic. So that's worth bearing in mind. In a severe COVID pandemic, it's projected there'll be 64 million ill persons and 3.8 million admitted to the ICU and 1.9 million not making it. And there are a lot of variables that determine this, right? They admit in the article that these are projections, these are based on how well we are able to contain this in the community, how well we are able to provide resources that can slow it down for infection rate, for progression to complications from the illness, and to dying. And other variables for that include being able to study and provide medical therapeutics, medications that can prevent infection, that can thwart it and keep it from hurting people, and also the time to developing a vaccine. So the first part of this article talks about the burden on the healthcare system in the setting of this illness. So somewhere between 1 million and 4 million people admitted to ICUs. And if each ICU room is a proxy for the ventilator in that room and the healthcare staff needed to resource and provide care in that room, then you can see that there's a lot of resources we're talking about that will be needed to accommodate these patients. When you've heard about flattening the curve, the whole idea is that these 1 million to 4 million people won't come in all at once. If they're spread out over a period of time, then we can accommodate them in theory and provide the type of critical care they might need to survive. So the next section looks intuitively at capacity. So this talks about the number of hospitals, the number of ICU beds. There are about 85,000 adult ICU beds available at any given time. 62,000 full-featured ventilators with a stockpile potentially of 10 to 20,000 more. So that's sub 100,000 ventilators in theory that are available now prior to some mass production. Who knows if that's on the horizon. So you can see that the demand for ICU and ventilators is predicted to outstrip the available supply. And you can talk about strategies for that, public health strategies like making more. You can talk about containment so as to flatten the curve so that those 100,000 could be provided each month. And you can see that 10 months of 100,000 rooms and ventilators could accommodate 1 million people. That would require a really flat curve or some sort of other intervention that would reduce the demand, like people getting healthier or some other technology emerging to help people. And I'm looking to see if there's any thoughts or questions so far on the context here of COVID. I'm not going to go down technical rabbit holes because I'm not the expert to provide insight on all that, but does anybody have questions? I'll look for them out on the side here. We're going to get into the interesting part, what I think is the interesting part here, the part while we're here today, and that's the next section. Ethical values for rationing health resources in a pandemic. And before we step into their recommendations, think to yourself, upon what principles and values would you make tough decisions about who gets access to healthcare resources? Is it to each according to need? Is it to each according to the likely benefit? Is it to the value of the individual assessed in some way? What would make sense to you? Do you have your own instincts? And I'd like to invite you to put some words on that in your own mind. What matters most? What principles should matter most? Because if you haven't read the article, I'm going to tell you what these authors say are your options. And they're going to tell you, I think controversially, how ties should be split. How would you split a tie? So there's a chart here, table 2, in this article. I'm going to describe it for you. It says, Table 2, ethical values to guide rationing of absolutely scarce healthcare resources in a COVID-19 pandemic. On one column, we have ethical values and guiding principles, and in the other column, we have the application to the COVID-19 pandemic. So the principles are, and I'm going to go through them broadly for you, maximize benefits, which includes saving the most lives and saving the most life years, meaning maximize the prognosis for the individual. So maximize benefits, number of lives, and most life years. We'll come back to that. Treat people equally, first come, first served, versus random selection. They give you two choice. And this is the, how do you split a tie? First come, first served, or random selection. Promote and reward instrumental value, parentheses, benefit to others. So this could be done retrospectively, where you prioritize those who have made relevant contributions, or prospectively, priority given to those who are likely to make relevant contributions, and then giving priority to the worst first versus youngest first, right? So maximize benefits, treat people equally, promote and reward instrumental value, and give priority to the worst off. And in the COVID, these are their recommendations about how to apply these principles. Whatever strategy for rationing resources saves the most lives receives the highest priority. Whatever method of rationing saves the most life years or maximizes prognosis for patients receives the highest priority. They argue that a first come, first serve algorithm should not be used. And they argue that random selection should be used to break ties. Random selection, lottery style. I'm interested in your reactions to these. I'm going to tell you my opinion.
Jason, when you say to break ties, do you mean like ties between people who are equally qualified for a ventilator? Is that what you're saying? Break a tie?
Yeah, that's what I mean. Is if you imagine a situation where two very sick people are in the ER, COVID or not, right? COVID infection or not. Two very sick people are in the ER. It is the ER doctor's opinion that both of these patients need to go to the ICU and need to be intubated forthwith based on the standards of medical care. They call the ICU doctor, ring, ring. Hello, ICU doctor. Yes, how can I help? I have two patients that need to come up there. ICU doctor, well, I'm sorry, I only have one room, one vent. You're going to have to decide which one. How do you break that tie? That's the question.
So and that's the kind of decision that we're trying to make when we, or at least that these authors are trying to make when they propose these principles and how you should use them.
Yes. So for example, if you have an algorithm that saves the most number of lives equally, remember that received high priority, and saves the most life years, that receives highest priority. If you have two patients who will have equal number of benefit to their prognosis, how do you choose among them? And so they pit as the straw recommendation, first come, first serve. Oh, whoever showed up first versus random selection. Well, because these are equal, all things considered, let's flip a coin and whoever heads up goes to the ICU.
But it seems like it would be so easy to just use first come, first serve. I mean, that's what we're used to using in practice. If my pediatrics ward is full, I know that a kid coming from a rural hospital is going to get the best care at University Hospital. But if I don't have a bed, I'll have them go to another hospital for care, right? So first come, first serve, we know how to do that. What's so wrong with it in this situation?
Yeah, good question. So first come, first serve works pretty darn well when the queue is short and everybody will ultimately get access, right? It doesn't feel morally wrong to say, well, you got here first, so you're first in line. You're right. We totally do that with, even with the ICU, that as a standard practice, the ER calls with two patients who need to go upstairs. But if there are enough ventilators, guess what? The person in the ER can be ventilated in the ER. And so they can wait for the room and the resources upstairs while they're treated safely and cared for with standard of care in one area. But if all the vents are up in the ICU and you have to choose, then does arriving first make sense as the triage strategy? So there's an interesting thread in the ethics literature about whether first come, first serve makes sense. In a way, in the clinical world, as clinicians, it feels right? It feels like, yeah, you got here first, then in some way that conveys that your need is greater because you're here before me. And furthermore, actually, I find something very compelling about it, which is once I've established a therapeutic relationship with a patient, I'm connected to them. The next person who comes in some way has to be prioritized less than the person I've already established a relationship with. The criticism is that the formation of that relationship and the time of arrival to the clinic or to the ER or to the ICU or to the operating room, the time of arrival is subject to the vagaries of human existence and not something for which an individual should be blamed or praised, punished, or rewarded. So this is argued by Richard Fine out of the Baylor Health System. Their policy for triage actually strategically moves away from a first come, first serve basis on the argument that it is often the poor and the disenfranchised who do not have access to resources that can subsequently delay their entry into the healthcare system. So why double punish somebody who's poor and doesn't have access by saying, well, if you get there a little later, then we're not going to treat you, or you're going to get less or lower priority.
And I mean, serving the public, sort of serving, we're a public institution. I mean, isn't serving those disenfranchised people a pretty core part of our mission and our values?
Say it again.
I was just bringing out, that concern feels particularly salient to me because we are a public institution. I'm very proud to work at a public hospital. So we have to make sure that that our specific attention is going to those disenfranchised people, because that's part of our core mission.
Excellent. Yes. Part of the core mission is to serve the community in which we are situated. And our community is disparate and different and has a high rate of poverty and low access to resources. And our health systems, including the ones in which I work, have made it their bread and butter to reach out to the community to provide care. And who knows better than our health system that some people have trouble accessing the health system. I just think about the simple fact that when I have a clinic, some of my patients need to take 3 buses to get to their appointment. And some of my patients have very little control over the obstacles that keep them from accessing resources. So I think, yes, the point is particularly salient. There's some chat going on in our side chat room, and I want to respond to that. You feel free, Rachel, to look and see what. Oh yeah, so especially in COVID, it seems harsh to punish patients for arriving late to the ER. If part of our medical recommendations, thank you, Ryan, it seems harsh to punish them for not coming to the ER when our recommendation was to say stay at home, right? Well, now that you're here too late, but you told me to stay home. Makes sense. It also doing first come favors the well-connected and closely located people over the less well-connected. That's true. And that's a fair criticism, Dr. April. That's a fair criticism, especially if you think that being well-connected and closely located is not a morally relevant feature for triage. In fact, the first come, first serve almost says explicitly, those who get there first, by hook or by crook, by walking across the street or by calling your limo or by knowing the good doctor who works at the hospital can get you admitted promptly, right? That's first come, first serve rewards that.
And then, this point has just come up from Ryan Reyes about the experience of clinicians. He says, removal of resources from a patient who's already on a ventilator to, quote, maximize benefits seems too distressing to be implemented. The moral weight of this action seems so much greater than that of inaction by not taking away a ventilator, by not giving a ventilator. So here we're getting into this, the nuts and bolts of what maximizing benefits could look like for physicians. What can you break down this this guiding principle for us a little bit?
Yeah. So let's just dwell on that for a moment. Let's sit up in that chair for a minute and talk about what should be our guiding principle. We've got first come, first serve. We've got, remember, their first priority is maximizing benefit in this article. We got lottery. And at the heart of it, you've got doctors and patients, and you've got a health system and a community, 2 parallel types of relationships. The guiding principles should be a fiduciary responsibility to provide care, should be stewardship of the resources to which they are entrusted, the doctor and to provide fairness, which we're actually talking about right now. What is fair? right? What is fair? And that's what we're going to sit in terms of this big cozy ethics chair. We need transparency. So this conversation we're having right now should be the sort of conversation that if it turned into policy, that the public could hear it and say, yeah, okay, I can buy in on that. I understand doctors have to make tough decisions. Health systems have to make triage algorithms, and I support that. So we need transparency. So credit to Dr. Emanuel and his colleagues to publishing this with the editors of the New England Journal of Medicine in a space where it can be openly criticized by experts and the public, right? This is the conversation we should have before the crisis hits, right? So that transparency and sense of accountability to the public we serve is really, really crucial. So some people are commenting on, and you mentioned it, Rachel, about this, how the doctor is going to make a decision. And so I want to take a step back and give you a little sense of context of where I'm coming from on this. So I worry that by focusing exclusively on who of those two patients in the ER is going to get that vent and that ICU room upstairs, by focusing exclusively on that, we are shortchanging our moral reasoning. Our moral reasoning absolutely should be cut and tested against tough cases. But we have to back up and walk through all the ordinary moral reasoning, all the principles that I just talked about and that we've been talking about, and I see going on in the chat about maximizing benefits. We have to walk through those through ordinary circumstances and tell ourselves what's different about this one that we should change or abandon or reprioritize our principles. My opinion is we shouldn't change our principles. And the way I think about moral reasoning is, I'm going to see if my hands work here. Yeah, that's TJ, and this is my hand. And this is one ethical principle. This is another ethical principle. When they come into conflict, this one doesn't just disappear. This one has to adapt and get prioritized relative to this one. It is still applicable, so that as the situation changes, it might turn out that this principle still rises and influences this other principle. So this principle of maximizing benefit and promoting fairness and honoring doctor-patient relationships and the stewardship that the health system owes to the community, these principles are going to have to jockey and push against one another in a healthy tension in order to resolve cases. So how we get a little too far abstracted is that we jump into the desperate situation. So let me tell you about two models for moral reasoning, two hypotheticals that I think inform and shed light on this particular type of triage process. So one is the classic trolley car. If you're a fan of The Good Place, the TV show, or Philippa Foot or Judith Jarvis Thompson, or just an ethics geek, or just you've paid attention, there's the ethics of the trolley car situation. And so how it's posed is something along the lines of this. You have a trolley car and its brakes are broken, or the driver is asleep at the wheel and it's heading towards 5 workers, and it won't be stopped, can't be stopped. It's going to kill those 5 people. Unless a person who is standing next to the tracks is pushed in front of the trolley car to stop it. Should you, if you were standing next to a person who could be pushed in front of the trolley car, push that person in front of the trolley car to stop it from killing 5 people? That is, should you take a deliberate action to kill 1 person in order to save 5? That's how it was originally presented, this trolley car situation. Then it was tweaked, and there are myriad tweaks on this principle, all of which force you as, okay, by the way, philosophers can be jerks, right? This is terrible. When you think about it, it's terrible. If you watch The Good Place, then they make it real because they demonstrate the trolley car situation and there's just blood everywhere and there's screaming, which there should be because, God, that's terrible. So I'm glad I said that. In all of these situations, you're forced to weigh the good of the few against the good of the many. The sense of moral culpability an individual has by taking an active process and killing somebody as opposed to allowing somebody to die. In some permutations of the trolley car problem, you have an old person on one track and a young person on another, or you have an engineer or an astronaut on one and a random person of poor means on the other, right? It forces you to weigh all these things that are mentioned in the table by Ezekiel Emanuel, like the life years of the individual. Oh, well, maybe that would argue for taking out an old person against a younger person, or the prospective instrumental value by prioritizing those who are likely to make relative contributions. So you save the engineer, but not the homebody, right?
So it seems like Ezekiel Emanuel is a real push him in front of the trolley car type.
You betcha. Yeah. And he wants to, and he's going to put, and he's also going to save the more productive person and the person who's paid their dues. In the article, when he talks about retrospective and prospective instrumental value, retrospective is people who have volunteered to be in part of a study related to COVID. Those people should get rescued first. And doctors and healthcare workers who could be put back into the healthcare system to treat other COVID patients or other people who might be injured in a pandemic, those people get prioritized first. He is absolutely a consequentialist. He wants to promote the maximum value, and he's not afraid of saying, well, sometimes I'm going to have to rate some people as worth more than others based on how long they have to live and based on their instrumental value retrospectively and prospectively.
So I will tell you that gets to the heart of one of the deepest conflicts that I have with these guidelines. I practice with a sense that people have what I call inherent value, meaning we're not valuable just because I'm not valuable just because I'm a pediatrician, because I can help some little kids. I'm not valuable just because I'm extremely funny and charming. I'm valuable because I am a human being. And I think of my patients the same way. That allows me to provide good care to kids with severe disability, to kids who are near the end of life. And what worries me about these guidelines is there's a suggestion here that my sense of the fundamental value of human beings is a luxury. These guidelines suggest that in a pandemic time, I can't act out of inherent value, but I have to act out of people's instrumental value. Is that true? Do I have to move away from practicing medicine from a place of inherently valuing human beings?
Thank you for being awesome, Rachel, and valuing people not because of their use, but because of their intrinsic worthwhileness. I think that's a very healthy approach. And well, I put that to the group. Do your moral understandings change in a time of crisis? Surely they're tested. So let's look at a couple of responses to that question. Dr. Pearson's instinct about the intrinsic value of individuals versus an instrumental value approach. So what might Ezekiel Emanuel say to your question? So Ezekiel Emanuel might say to your question, let's put the best spin on it. Dr. Pearson, I empathize with the need to promote the sanctity of life and respect individuals regardless of their instrumental value. And I really don't want to make decisions between one person or another. But I'm imagining that there are going to be 1 to 4 million people needing an ICU bed and ventilator, and there's only going to be about 100,000. Maybe the auto workers make a bunch of ventilators, or we import some, or maybe somebody's been hoarding them and releases them, and there's 200,000 ventilators. Still, there's a delta of 800,000. How are we going to choose between all of these people who have intrinsic value? So Zeke, the response to Zeke could be to say, okay, Zeke, I hear you. We're going to have to make decisions that harm people who have intrinsic value. But why don't we prioritize avoiding bias against people whose value is unclear and in some ways immeasurable? Isn't that what we mean by intrinsic value? Is that who the heck are we to judge who is worth living and dying? I think that's a very powerful critique against their article and the point that they make about instrumental value. In my opinion, our triage algorithms, our solution to this problem, should hold fast to our deep beliefs that people do have intrinsic value, and we should not focus on saving the lives of people who are smarter and are in thought some way to be more useful to society. I even struggle with their ranking of healthcare workers to be intubated over non-healthcare workers, partly because of practical issues. Are those people, I mean, his argument is that those people are going to get back into the workforce to care for COVID patients, but are they? If they're intubated with acute respiratory distress syndrome, you're going to just pat them on the butt and get them out of the ICU back to work? No, they're going to be out of the healthcare system for months, or they still might not survive.
I also
So,
worry.
struggle with that.
I also worry about how that affects our credibility as a profession. If we as a profession are designing these guidelines, and if we as a profession are making these decisions on the ground, then how will it be viewed if we've decided that our lives are more valuable than other people's lives?
Rachel, you're right on. We got Dr. Seidner riffing with you on that. He says, how do we assess an individual's instrumental value at the moment of decision without knowing everything about the patient in front of us? How does this get applied to children who have not yet manifested the instrumental value? That's awesome. Now, Dr. Emanuel might say, well, again, children get the priority because if they're that sick and we can save them, they got their whole life ahead of them. That goes to his maximizing benefit, not necessarily to instrumental value. So he might split the hair that way. Dr. Bergeron adds that every scheme will have its limitation. We can't know everything. There has to be some leeway in the guidelines for judgment, which inherently opens up this scheme to bias in its application. Great point.
And the real Dr. Seidner would like to remind us that he shared his link with the PEDS department. And so he's not actually behind every statement labeled Dr. Seidner.
Oh, there are not 9 Seidners? Okay. Thank you for that reminder, because there's some insightful comments and interesting. We don't know how to attribute those comments. They may or may not be Stephen Seidner. So 2 comments about the trolley car problem. One is, I love it. It's a way to cut your teeth and test your principles, right? And I'm happy to say that promoting maximizing value is reasonable. Here's what I worry about the trolley car problem and its application to this situation. It is totally concocted. It is, I mean, it's a setup. You strip the situation of all of its realistic details. The whole purpose is an exercise, a caricatured exercise in moral reasoning, deliberately devoid of the nuances of real life. And what I worry about is in moments of crisis that we lose a sense of situational awareness. And this lesson comes from Dr. Bergeron, who has taught me and others about how to stay grounded in the moment of a crisis. And I think if the trolley car invites us to fast forward to the tough case where we have to make a black and white decision, we have to make a horrible decision, what do we do? And what I don't like about it is it like lets us cut our teeth not only on reasoning, but on bias. I would want triage algorithms that are explicitly unbiased, where we say, we're not going to make a decision based on your instrumental value. You don't get prioritized because you're a healthcare worker or a good person or a bad person or a rich person or a poor person. I want all of the work of triage to be done with the usual assessment and tools. And that, I believe, is where I'm going to stake my claim, is that we can develop algorithms that comport with standard clinical and medical care and the usual ethics of clinical decision making. 90% of what we're going to be deciding in the setting of a crisis, we're going to get through with the usual reasoning. Still, our providers are in extreme distress because they're worried that they're going to be on the front lines having to make this decision, right? They're like, oh my God, what am I going to do when? And to the chat conversation, that's the point of guidelines, is to support clinicians with recommendations that have been endorsed by their leadership so they don't feel out on a branch. And I want to talk, Dr. Pearson, about moral distress of the provider. And I want to comment that the purpose of the guidelines still allows for leeway for clinical judgment, but they are needed in advance because we shouldn't be making the rules of the game while we're playing the game. If the purpose here is to be transparent and fair for the public, then we need to make our algorithms in advance. And that's what we're talking about. That's what's being worked on in our community. We want our health systems partnering to talk about what are the best ways to triage resources when the surge comes. And my argument is, why don't we use the usual standards of care? And we can get through the bulk of the tough decisions by staying calm, being situationally aware, and relying on our usual algorithms about risk and benefit for medical interventions. And we don't have to get to judging people on their worth.
And Dr. Or Jason, we have just a few minutes left, but we have a couple of attendees here who have really particular experience in triage and in working in resource limited settings. We're joined by Dr. Ruth Berggren, who has a wealth of experience from managing an HIV ward during Hurricane Katrina. We're also joined by Dr. Rick Hodes, who has, forgive me if I pronounced that wrong, but who has practiced in Ethiopia. And I wonder if we could give each of these folks a couple of minutes to share some wisdom from their perspectives. Dr. Berggren, would you unmute?
Hi there. Let me see if I can start my video too. Thank you for inviting me into the conversation. I'm really enjoying your thoughtfulness and the way this is being presented. What I can say about Katrina is there was not clarity about what sort of triage scheme we were using, and what we were using inside of the hospital turned out to be different than what people were using outside of the hospital. So I had the experience of triaging somebody as being a top priority and getting them out, and then only to learn that someone else reassessed and overrode my triage and put them last priority. So an example would be a patient with advanced HIV, low CD4 cell count, needing dialysis. My perspective was this person hadn't been given a fair chance at antiretroviral therapy, was young, a graduate student, and in my opinion, fully salvageable as an HIV patient, but someone who didn't have my expertise in HIV care came along and said, oh goodness, this person has no T cells and she's on dialysis. It's a hopeless situation. We should not prioritize her for transport out of New Orleans over other people who are in much better shape. So this is a reality. To Jason Morrow, I want to say that in an ideal world, I do want us all to be adhering fully to our principles and our thoughtfulness. And I've also taught many times that you're never in a vacuum and you shouldn't feel like you have to make rushed decisions because there's nobody else to talk to. That's almost never true. Even in a blackout, like there's no electricity and there's people shooting outside, you still can talk to your teammates. That's a fact. And I just want us to remember that your team is your lifesaver. However, this reality that we're not just one hospital or one team with that one patient, there are other entities and people are going to be transferred from A to B to C. And if we are all working with different philosophies, different values, and different triage schemes, then all the work that we do to try to make the best decision for that one patient is just going to be thrown out the window because we haven't gotten ourselves together as a community about how we're approaching these decisions. So I didn't give you a solution to the problem, but I'm just clarifying the reality of an emergency. And it's two things here are true. It is always true that there's someone else you can talk to. You do not have to be Anna Poe, in Memorial Hospital running around euthanizing people. You do not have to do that. At the same time, you cannot fully have all of the time and all of the consultative resources available to you in a crisis. And you have to recognize that you're dealing with multiple kinds of people, and you have to communicate with them clearly. And you can't go quoting Greek philosophers to the first responders who are coming to carry your patient from hospital A to hospital B. That's, well, I'll stop. Thanks.
Are you throwing shade at me? I'm totally going to quote Socrates to my EMS responder when asking for help. Oy. Ruth, that was beautifully put. Rachel, I want to let you comment. I'm sorry.
Well, Ruth, I find that very reassuring. You know, I certainly found in my residency, and I find in my practice as an attending, that trying to make decisions on your own never makes sense. And so thinking of my immediate team and then thinking of the backup I would have with our ethics consultants and the larger community is a real comfort to me, and thinking of how I personally would deal with the moral distress of a crisis situation. So thank you so much for that. I wonder if we might hear from Dr. Hotz. Are you able to unmute yourself?
Let's see, can you hear me now?
Yes, thank you.
Fine. Can you see me? I don't know how to turn on the camera. You are, now I don't hear you though.
Sorry, I muted myself.
Okay.
There may be a video button if you hover your little mouse over the bottom of this video screen. But if not, audio is fine.
Okay, maybe there. No, wait. Okay, can you hear me?
Yes.
Okay, yeah, so I don't know how to do the video. Anyway, I've been a doctor in Ethiopia for 31 years and even longer, I guess. And right now I'm hiding in Eastern Tennessee to let this thing pass. But I have to make these sort of life and death decisions all the time. I have limited funds. In the latest incarnation of my medical career, I am an expert in spinal deformities, and my surgical partner is probably the best deformity surgeon in the world. He's in Ghana. I'm in Ethiopia. We send patients to Ghana. We put them in ambulatory halo gravity traction for 4 to 5 months, and then they get operated on and they straighten their backs, and we're able to correct TB kyphosis and congenital scoliosis and things like that pretty well. So I have to make, and I have very limited funds. I'm always begging for money and so on. So I have to, when I do have some money available and I have to send 10 patients to Ghana, I have to choose who am I going to send. And basically I'm playing God. What I've decided is the only thing worse than playing God is not playing God. And for me to just take a list of my patients and choose them randomly would be crazy, because there's a lot of other factors that I have to consider. So I have to, it's like choosing a medical school class. You're trying to get a variety. You're trying to get a fair number of males and females, different diseases, different ethnic groups, and so on. It's not easy, and it's clearly imperfect, but it's a sincere try. When I was working during the Rwandan crisis in the mid-90s in Goma, Zaire, I was in charge of the health of 25% of Kibumba refugee camp. So that was 50,000 people in my section. And we had a hospital, we had lots of different primary care teams, and we had people going out into the field. We were doing demographics quite carefully. And I had worked in cholera as a medical student in Bangladesh. So I knew that during a cholera epidemic, you have a lot more patients than you know what to do with. Before I left for Goma, I called a rabbi, and I sort of said to myself, I don't know if I'm going to believe this guy, and I don't know if I'm going to do what he says, but I do at least want a spiritual opinion on how I might do triage in this situation. So I presented this to him, And this, he said, I am not prepared to make this decision. And he consulted some very, very senior guy. And that person sent back the message that I shouldn't make the decision on who to treat first and who to treat second, that I should take patients in the order they came to me in. And once I started working on a patient, I had to finish with them. Like, you don't say, okay, you get 20 minutes and that's it, and then I'm going on to the next person. So we got into the field, and we would, there were 5 of us, and we wanted to be within sight of each other. So we would spread out, say, 40 meters apart. And we would just work as field medics doing peritoneal hydration, which is my preferred method of hydration in this situation. And that worked quite well. And we would just go, work forward from one patient to the next person to the next patient, and go back and train the people to take care of themselves. It's as good as anything we could have done. Instead of going around and saying, okay, we're only going to treat, we're going to give priority to the less than 30s. We're not going to treat the 70-year-olds, and so on. So that's what we did, and it worked fine. These are very difficult situations, very difficult things.
Dr. Hodes, can I ask a question?
Yeah.
Did you ever feel like you had to make a choice between one person and another?
No, I didn't, but I did sometimes feel like it was the end of the day and we had to stop. And we had to stop for our own safety. So it's like, I'm sorry, I can't help you.
And if you don't mind, may I ask, knowing that there had to be an end of the day and there might be other people in queue, other people in need, but you also had to look out for yourself as a provider, how did you anticipate or think about those moments? I'm thinking of that as an analog to the providers now who are worried about having to choose between one life and another. It might be, I'm imagining it would be tough to know, I don't know when I'm going to call this. I don't know when I'm going to call the end of the day, and sort of fearing that moment because it's so full of symbolic and practical meaning that lives might be at stake.
Yeah, I mean, what can I say? There's no easy answer. I would just say, this is it. It's getting dark. I'm out of here. Knowing that if I didn't leave at that moment, there could be chaos, and that would be the end, and then I wouldn't show up. I wouldn't be around for the next day.
Thank you so much for sharing your experience. I loved your statement. The only thing worse than playing God is not playing God. And it's also reassuring to me to hear that you didn't, in practical terms, find yourself having to choose between one person and another, even though you did at some point, have to sleep and eat like human beings must. I wonder, that actually brings us to, I think, what we should make our last point in the interest of time. But I'd like to talk a little bit about resilience and how we as a community and we as a center hope to promote the resilience of our healthcare providers during this crisis. We know many of us are familiar with the concept of moral distress. So moral distress is that feeling you get when you know what the right thing to do is, or when you know what your principles are, but you're not able to act out of them based on systemic or situational constraints. I call it the feeling of not being able to be the doctor you want to be. Many of us fear being overwhelmed by moral distress in this crisis. We fear being unable to care for our patients. We fear being unable to act out of our values. And so to me, having this conversation, recentering ourselves on our fundamental values and being reassured by experts who have really been there, that even in crises, you can continue to act out of your fundamental moral values. to me, that's very valuable. And I think that will help me be resilient during this pandemic. Dr. Berggren, would you speak a little bit to resilience and how we can support it?
So some of you have heard me say this before, but let's keep repeating it and repeating it and repeating it. We can't control what's happening to us, but we can control how we treat one another. And so I'm calling on everybody who's joining us here at PanPals, Screenside Chats, to take this to heart and go forth from here and repeat it to other people. It does save lives. The second thing I want to say is when I was climbing Mount Kilimanjaro in September with my family, I learned something from our lovely Tanzanian guides. And we had a group of people that were disparate in age and physical abilities, and sometimes we'd get separated from one another, certain ultra distance runners getting ahead of the crowd. And the guides would, when they saw this happening, they would call out, "One team." And then we were all expected to respond in chorus, "One dream." And then they would say, "One dream." And we would say, "One team." And this kept everybody together. And the super athletes were together with the, over 55-year-old mothers who were together with the 20-somethings. And we all made it to the top. And so the reason we made it to the top is that we supported each other, and at all times we're thinking about the benefit of the whole group and not the benefit of the individual. So one team, one dream. San Antonio is known for the Spurs. What are the Spurs known for? They're known for being an outstanding team and not having a bunch of superstars. And so I think it's a great motto for San Antonio. We have to swallow our egos. I have to swallow my ego every day, and I have to remember to watch my tone when I think I know what's best. So swallow your ego. This is the real world. And the last thing I want to say, and this has become my sign off on my emails, is Shalom y Salud, which is peace and health. Thanks.
Well, Shalom y Salud to all of you. And thank you so much for joining us for this conversation today. Dr. Morrow, any final words from you?
Stay calm, be informed, talk to one another, find creative venues for connecting with one another. I think we are on the same team, and as is always the case, if we have concerns, we need to voice them. That's part of dealing with moral distress, is taking those feelings that you can't do the right thing and talking to other people about them respectfully, advocating for yourself and one another. I feel moral distress. I feel moral uncertainty because I'm not sure exactly how the right thing to handle those tough cases is. But if we rely on our moral imagination and our long-held moral commitments and priorities, we're going to get through this. These decisions are tough, but honestly, they are more similar to the ordinary decisions we make every day than they are different.
And thank you so much. So for everyone out there, we're going to be continuing these conversations twice a week about ethics, about humanities, and about the moral values that animate our work. This is the PanPals program, and the CMHE will be offering these discussions throughout the crisis and beyond. So we really want to assure you that we are on your team. We are here to talk things through with you, to support you, and we're just so proud to be on the team with all of y'all. Okay. I'm going to end the meeting, you guys. Thank you so much.
I'm going to sit here awkwardly.